Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
And welcome, everyone. My name is Renee Garrett, and I am your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and offered for 0.1 ASHA CEU. Here are the financial and non-financial disclosures. The financial disclosure for Lisa Milliken is that she is the Director of Research and Program Development for Regency IHS. She receives an honorarium from SpeechTherapyPD.com for her podcast participation. Her non-financial disclosure is that she is a speaker for many other organizations, including Summit Professional Education, Calibri, MedBridge, and other live conferences for state and regional associations and organizations. My financial disclosure is that I'm a paid employee of a private consulting firm in the Commonwealth of Virginia, as well as adjunct faculty for both James Madison University and Old Dominion University. As the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars on SpeechTherapyPD.com, I do receive financial reimbursement. My non-financial disclosure is that I am the Secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our podcast guests, Lisa Milliken, MA, CCC-SLP, FNAP, CDP, RAC CT, CADDCT. Lisa has served as a practitioner, regional manager, vice president, consultant, compliance director, and education specialist. She has lectured at the state and national levels with over 400 professional continued education courses on topics of importance to healthcare professionals. She's also a certified Alzheimer's disease and dementia care trainer and has mentored team members nationwide in senior retirement communities on clinical programming for the past 30 years. She is the Director of Research and Program Development for Regency Integrated Health Therapy Consulting. She is also the Senior SLP Supervisor and Consultant for Bright Success and is the owner of Milliken Healthcare Consulting, where she teaches conferences across the country. Lisa is a member of the American Speech Language Hearing Association, where she serves as a state advocate for Medicare policy for Texas and is the president of the Texas Speech Language and Hearing Association, or TISHA. As a distinguished fellow of public policy for the National Academies of Practice, and she is also a board member of the Kingwood Humble Aggie Mom Club and lives in Houston, Texas. Welcome, Lisa. Thank you so much for joining us.
Thank you, Renee. And thank you, everybody who else is joining us.
So we've got so far a public school.
Okay, I see public school and acute care. And other people typing in. Also SLP public school, early intervention schools. So interesting because that helps me think about the setting you're in, and if you're working with pediatrics or adults. I work a lot with adults, but during COVID, I started working more with children as well. Started teaching more about pharmacology with children and working with people with disabilities, developmental disabilities of all ages. And I found in those settings that we really had to look at the medications of those with developmental disabilities who had had seizures. So if I was working with someone with autism, there were a lot of those people either with an early onset or an onset around middle school or high school with seizure activity. So they were taking those anticonvulsants, and that definitely was affecting their cognition, which is kind of weird with that because it's either the cognition doesn't completely finish developing, and then the seizure medication keeps it from developing even more. And so it's kind of both.
That's interesting too, because I worked in the hospitals for off and on. Oh gosh, what year am I in practice? Almost 15. And I just took on a role this past January where I worked more with patients with IDD, and a lot of them do have autism diagnosis, seizure disorders. And so that's one of the things we do when we do our initial chart review is the medication check review. And it's astounding how many people are managed by so many different specialists, and the specialists aren't necessarily chatting with each other, nor are they
Right.
always looking at those interactions. And I think that is, just a great place to start by talking about a lot of the pathophysiological changes that can lead to that drug-induced cognitive impairment. Because I think, a lot of times for us who have worked in acute care, or even like me, who I worked in IPR or inpatient rehab and long-term acute care first, our patients were managed in-house. So the physicians and the specialists were chatting with each other. And I think a lot of times when we see polypharmacy or drug-induced changes, we're thinking about that acute care setting where that may be something related to anesthesia or surgery. And while I know that we'll probably talk about that too, I think, just more of a global perspective may be a great place to start.
Yeah, so some of the pathophysiological changes that happen, first of all, I always want to point out the blood-brain barrier. And so that's usually more intact with younger people unless there's a reason, some type of trauma or something that's affected it, but it can start to break down. Our brains are the only organ in the body with its own security system. That's what I like to explain the blood-brain barrier as. And so, there's some medications I remember studying in grad school about we can't, if they have Parkinson's, they don't have enough dopamine. You're thinking, why don't you just give them dopamine? Because it can't the brain barrier. So they give large amounts for a little bit to cross over, which led me into this whole intensive study of, the meds for Parkinson's disease. And there are certain toxins that they can't hurt a person because the blood-brain barrier is going to protect their brain from it. But if you take an overdose, it's going to get past the blood-brain barrier and it would, kill the brain. But it protects the brain as much as it can unless you seriously abuse it. But when that barrier starts breaking down, then a person can get dementia, they can have damage to the frontal lobe, they can have all kinds of things that then leads to cognitive changes, as well as others, as well as the body just not working. So the blood-brain, the permeability level of that blood-brain barrier is one of those pathophysiological changes that happens for different reasons. I look at a lot of it from an aging standpoint, but it could be from a disease standpoint, could cause the permeability to change, and then the brain is no longer protected as well. Other things is the neurochemistry of the brain. So if you think about all the different neurotransmitters, some medications block neurotransmitters, and so the synapse is not getting across. Some medications try to speed it up or keep the neurotransmitters from breaking down, like acetylcholine, and make it all the way across. So those are the acetylcholinesterase inhibitors. There's a lot of, without saying there's going to be a test on this, you have to remember all the things we're talking about, just to say, know that different people's neurochemistry is different. There's a lot of different neurotransmitters, not just acetylcholine, serotonin, and dopamine. There's a lot of others. And so how each person's brain work depends on the effectiveness of those neurotransmitters and if they're getting blocked for some reason. And then we have to give them a serotonin uptake inhibitor or something. And so the neurochemistry changes and it's very different in different people's brains. And there's often breakdowns and changes to that. The other two really big ones that you always want to think about when you think about meds is the pharmacokinetics and the pharmacodynamics. And so that will change. So when a child, for instance, is growing and their brain is developing, their whole body is developing, all their systems are developing, especially as a little child, a baby, then, you always see on medication like Tylenol or something over the counter, or even a prescription drug, they can't have as much of a dosage because their body is not finished developing. The pharmacokinetics and pharmacodynamics is not finished developing. And then the opposite happens in an older person. So somewhere around the 60s, it could be in the 50s if their body is chronologically different. They've abused it through the years and their kidney and liver function is kind of shot. It could happen a lot earlier than in the 60s. But theirs will start to break down kind of similarly to the young baby and the older person. So pharmacokinetics is the effect of the body on the drug. Or what does the body do to the drug? I wrote my little, without me telling you the whole paragraph, the summary is what does the body do to the drug? That's pharmacokinetics. Mm-hmm. So that would be like all of when you take a medication, how's it absorbed? How's it distributed? How's it excreted? How's it metabolized? How's it get around the body? How's it get out of the body? So that's what the body is doing to the drug. And that's pharmacokinetics. And that is vastly different in different people for different reasons. It could be, they also have diabetes. They also have different levels of inflammation in their body and different body fat ratios in the body. And so how that drug gets through and around the body and its effect of that is pharmacokinetics. Pharmacodynamics, the simple thing is what the drug does to the body. So that's why you're taking it. It reduces the pain. It stops the whatever, stops the constipation. It prevents the seizure. That's the goal really usually of the drug is the pharmacodynamics is what does the drug do to the body. So we don't study that as much because we hope it's doing what it's supposed to do, but we study pharmacokinetics a lot. For instance, with pharmacokinetic, when I'm working, and I'll get back to children in a minute, I'll spend more time there because I see several people in the schools. When we think of children, one of the questions that came up when I was teaching this course one time is, what if you have an 8-year-old and that 8-year-old, you look it up on the little chart and it says they need this many, milliliters of a medication because they're 8, they're not 12 yet. But what if that 8-year-old has the body weight of a 20-year-old? What if they're very overweight? So there's a lot of factors that go into that because of pharmacokinetics. And that includes the fact that there's probably more fat ratio to muscle ratio. Not saying there is, but that's one of the many factors. What if they're a bodybuilder, and they have a ton of muscle and very little fat? Not going to be very common in an 8-year-old, but meds are either fat soluble or water soluble, and some are combinations. So if you have 40% fat, a medication, a fat soluble medication is going to stay in your body way longer than if you have 20% fat. It's going to stay in, it's going to be very hard to be distributed. So everybody is different. And so it's not just, okay, they get this many milliliters because they're 8 years old, but they have to look at all those other factors of pharmacokinetics, and everybody's body is different. And with older bodies, their kidney and liver function starts to decrease when they're 25. Did you know that? If you're over 25, you've started to lose about 1% of your kidney and liver function every year. So when you're 75, you've got about 50% less kidney and liver function than you had when you were 25. And so it's going to take longer to metabolize a med and longer to excrete it out and all of that. So that's just some of the major changes. So if you have those and you're taking medications that has a very slight effect of a adverse side effect of decreased cognition. But that drug is staying in your body a long time because of your changes in pharmacokinetics, then you could have a dramatic difference. Or you're taking two medicines together. Now we've got a drug-to-drug interaction, and both of them are escalating that cognitive decline. And so they're working against each other. So just know that no two bodies are the same, no two children are the same, no two adults are the same, no two older people are the same, but they're all very different with completely different pathophysiological changes. And any prescribing practitioner is going to have to consider all those options when they give them the medication. And then, you know what I say the role of the therapist is, because I'm a huge proponent of interprofessional practice. We have got to all work together as a team. And one of our key team members is the prescribing practitioner, and they need us just like we need them. So if we see something weird is happening here, I'm seeing a side effect, an adverse effect, because they're taking this, after they started taking this medication, I need to tell the prescribing practitioner. And they are always usually thankful for that. I tell them that with great respect. But usually they'll say, thank you, because if nobody told me this, I'd think, well, she's tolerating it fine. Let's just keep it on her. They haven't told me about any side effects. But we all work together to say, do you know she's hallucinating? Or do you know that she's sweating profusely? Or that she can't recall, any information from yesterday? And I hate that, because if they're older, they're going to say, oh, she must have dementia. No, It's all mental status secondary medication. It's not dementia. And so anyway, we all work together to let each team member know. And the prescribing practitioner may need to just slightly decrease the dose, or they may need to deprescribe that, and that may need to happen gradually. We call it a gradual dose reduction. Or they may need to just switch to a different medication that does the same thing, that does not have this, like seizure meds. Think about that, because many of you probably work with that. If you work with children, there's probably 5 to 7 major seizure meds right now that they're going to pick from based on that person and the type of seizures and the length of them and the age, the pharmacokinetics. Can they risk the side effects of decreased vision or decreased cognition? What's the newer ones? What do we have more studies on? So they're going to consider all of that. And sometimes they can say, okay, you didn't tolerate this one well, but we'll switch you to this one, and that's working well for you. Very similar to people take meds for depression or anxiety. And it's kind of interesting on those. Let me turn my sound off on my phone. They're going to often say, has any family member ever taken a med? Let's say you have anxiety. Have you ever had a family member with anxiety that took a certain medication that worked for them? And the same is true for depression or even the anticonvulsants, they had seizures. Because if a certain med works well for a family member, it's probably going to work well for you. And if they've already ruled out this med and this med and this med did not work for one of your family members, like a parent or a brother or sister, they don't need to go through all those trials to figure out, well, let's see if it works. We don't know. So anyway, there is a genetic component to pharmacokinetics to figure out what works and what doesn't, that may have the least adverse effects.
Well, it's really interesting too, because I know when I have 2 adult kids, and my youngest, my son, when he had his wisdom teeth out, he had a really difficult time coming out of that little tiny bit of anesthesia that they give them. And he was an athlete. He was a swimmer, long distance swimmer, fairly tall kid. I think he was 17 when he got him out, but he had a really difficult time. And one of the things that the dental assistant told me was that she said it's kind of interesting, because you can kind of tell the kids who have maybe experimented with, like teens who have experimented with various substances, meaning drugs or alcohol, and those who maybe didn't, because the kids who tend to have a harder time usually have not ever experimented with anything like that. And as a parent, I was like waiting, but then also it kind of made me think about, again, our patients that maybe have these multiple medications, particularly mental health plus seizures, because we see a lot of that where they're on meds, maybe they're on a lot of psychotropic meds, and then moving into the population I'm seeing now, same thing. I just had a client who switched his home setting, and his new physician took him off of almost everything. He was on like 22 meds and they've dropped him down to 5, and it's like he's like a different
Great
person.
God. Yes.
Yeah, and it's so interesting.
Way too many medications, and they're all, if you're over taking more than 10 medications, you have like a 90% risk of drug to drug interaction.
Mhm.
And a lot of it is going to be a cognitive decline of a drug to drug interaction. And this med not cause it, but you mix it with this one and it does. So if you're taking a lot of them, there's a high risk of a cognitive decrease in function because of drug to drug interaction. That person was on 20, they're going to be confused and not able to function.
Yeah, and throw in a
That's
communication
interesting.
impairment. Yeah.
Yes. Yes, and then it's hard to figure out. I talk to new grads a lot about, if you go into a healthcare setting, don't be, or you will be overwhelmed. Just be prepared to be overwhelmed. When you go in, you're like, where's the MRI telling me where the lesion is? And instead you're like, they have like 12 diagnoses and they're on 20 medications. Then it's so complicated. You're trying to figure out what's what and what's the origin of this effect. Like, don't assume a tremor is Parkinson's disease. There's a high chance it is a side effect of a medication. So you have to figure out what's neurological. And if it's a real neurological deficit, I need to work on building a new neural pathway, to a crossover where there's dead space. So where the brain didn't work anymore. If it's not neurological and it's adverse effect of a medication, you can't build a new neural pathway to fix that. That's the side effect of that medication. Many, many times I've seen patients with tremors, but there's so many things that you think, oh, that sounds neurological, and it's not. It's adverse effects of medication. So I think the more that, and I did not learn this in grad school. I started working with a guy about 10 years ago who was a critical care cardiac nurse, and we were both consultants, but in an educational world, and we would create courses together and travel around and teach those courses for a company. And he taught me so many things about medications. We were mostly specializing in cardiopulmonary disease, but I just pick his brain all the time because he had been a chief nurse officer for the Air Force, and his wife, she was also an officer in the Air Force, and she was a public policy writer for the OIG. They're both brilliant people. So I learned a lot from them, and he taught me to look stuff up a lot. And you know what? I'm going to just throw this in there. There are apps you can put on your phone that's free, and I use these all the time. And I'll just tell you the two of the most common ones, so I'm not recommending them. I'm not paid to tell you about them because they're free, so it wouldn't happen anyway. But one is called Medscape. And once you go and it'll tell you about medications and diseases and all kinds of stuff. But if you go to the interaction checker, you type in all of the meds that person's taking, including the herbal meds, because they can, sometimes parents are like, oh, I'll give my child this, this, and this because it's helpful. That may be fine if it's just herbal, but if they're also taking something for a heart condition or for anxiety or for something else, it could be lethal to give them a prescribed medication and an herbal. So you can look them up to see. You just type them all in. I do this a lot with my home health patients or clinic patients. And it tells me if there's a mild risk of an interaction or moderate or severe risk causing death. Because sometimes they're not going to be prescribed two medications together by the same person, but sometimes they're taking them from another doctor. Or they got them from somewhere else, or their cousin gave them extra meds, or take this, it makes me feel better, it'll make you feel better. And that's very, very dangerous. So one is Medscape and the other is drugs.com. And drugs.com, you can actually click over, it gives you the professional version, like as a, healthcare professional or licensed professional, whatever level. But then you can click something else and it puts it into layman terms. You can explain it to the patient, the client, the family. It's medscape.com and I'll show you.
Yeah, drugs.com tends to be the one that I use.
Medscape.com. That's what that looks like. Where's the thing? There it is. Medscape.com. And then the other one is drugs.com. Where is it? See drugs.com at the top. So you can, I find that to be very helpful because some people think, oh, it's fine, it's over the counter. But you don't mix Benadryl with some things too. That can put your brain into, not good. So anyway, I keep throwing extra stuff in. I teach a lot about, so I don't want us to run out of time. Let me know if you want to ask me something else.
No, this is great. And I do, that's usually what I use is drugs.com because again, the population that I'm working with right now is a lot of them are on psychotropic drugs and anti-seizure meds. And so there are a lot of interactions, and they even on drugs.com will tell you food interactions too, whether or not people have any kind of food allergies or food. We get a lot of people with not necessarily full-on celiac, but gluten insensitivity, or casein is one I see a lot of now, intolerance, sensitivity to other dairy products, and those a lot of times will interact with these meds. So it's important to know. And not that you're, a prescribing physician or a pharmacist, but it is helpful for us to know because again, we deal a lot with medication training when it comes to a safety concern with, is the patient able to safely manage their meds as far as taking them, or do they need assistance? But that's part of it, is knowing that this could possibly be interacting, and you may want to follow up with your physician, or I can follow up with your physician when I talk to them about your progress.
A couple of minor ones, like simple, just to let people know, is one, if you're ever taking an antibiotic, you probably should not be taking dairy. And then people ask me, well, what about yogurt? I'm supposed to take yogurt, when I'm taking antibiotics. Take it 2 hours before or 2 hours after, and it will not interact. That's fine, but don't take it within 2 hours of the antibiotic, or you're going to decrease the effectiveness of the antibiotic. And another thing is almost nothing should be taken with caffeine. Caffeine is going to decrease the absorption of everything. The only thing I found you can take with caffeine is K2. If you need to take K2 for some reason, you should take iron, for instance, with vitamin C, and it increases the absorption. If you take it with caffeine, it decreases. You might as well throw it away. So there's so many people I find that just don't know those basic things. And sometimes you'll be working with parents of your client or your student or somebody, and they don't understand why their med's not working. And it's just a few little, and make sure they're hydrated. If they're not hydrated, you might as well throw the med away, and it could react pretty negatively. So don't take it with a Diet Coke or iced tea or cup of coffee or whatever, or Red Bull. Decreased hydration is going to keep that med from getting through, distributed around the body and metabolized and all that. Anyway, go ahead.
No, I think just kind of circling back to something I mentioned earlier when we're thinking about our patients who are post-anesthesia, the post-operative cognitive dysfunction, the POCD, talking about, when is that a concern and a bigger risk? And I know with our geriatric patients, like you mentioned, that there's a lot of factors, the absorption, the blood-brain barrier and all that kind of stuff, and the ability for your liver and kidneys to excrete those medicines. Because we do see that with the 86-year-old who comes in with a broken hip, and now she's post-op with her hip surgery, and she's now got orders for cognition in the acute care setting, but it's the meds.
Yeah, and because she's 86, they want to say she has dementia.
Every time.
Yeah. So some of the post-operative cognitive dysfunction is because of increased inflammation, and it's really neuroinflammation is what causes it. And anesthesia is one, but some other things that contributes to what's their risk. In addition to age, it's educational level, mental health, comorbidities, and contributory patient factors. I wrote it down so I could tell you exactly what the research says. Other factors includes other medications that they're taking, any infections that they may have, or maybe in the process of developing fluid balance. So a lot of times, whether, going into the surgery, for instance, they're not completely hydrated because they were told not to drink anything after midnight and how their body has those electrolytes with that fluid. For instance, if they're taking a diuretic, then they're already probably dehydrated by that point. Any metabolic disorders, any cerebral hypoxia. So hypoxia, you think decreased oxygen getting to the brain cells. So that's going to lead, to a higher risk of post-operative cognitive dysfunction. Pain levels, if the pain levels are higher, that can trigger, yet another factor that's influencing sensory deprivation, urinary retention, which can be caused from an anticholinergic med that I'll explain later, fecal impaction, pre-existing sensory or pre-existing perceptual deficits. So some people have a lot of those things going on, so they're automatically going to have a higher risk of a post-operative cognitive dysfunction. And we just kind of have to be prepared to work them through the process, when they come out of it. And a lot of times you see them at at an outpatient level or in a SNF, or maybe you're in a hospital at the acute care level and they just came out of surgery and you know exactly what to expect. But sometimes they go home, it's outpatient surgery and they go home, and then, you're dealing with them at some of their levels. So there's all kinds of things that can affect that.
I feel like I had a little bit of that when I had surgery a couple of years ago. It was outpatient and they sent me home, and I don't really do well with pain meds for the most part, and having all these other kind of weird things I'd never taken in my whole entire life. It does, and I think we kind of use the term loosely, but we say we feel loopy. Loopy
Yes.
is exactly how I felt, and I'm not geriatric, and I really don't take anything right now but iron, so, and my
Somebody
vitamins.
asked me, hey, what's the ICD-10 code for brain fog?
I
And
don't know,
then
but I
there's,
have it.
if you think about chemo brain, somebody asked me
Yeah.
also at Tisha at a convention, what's ICD-10 code for chemo brain? And there's kind of not one. You usually call it autonomic status. It's an adverse effects of chemotherapy. Not all chemotherapy, but some. But yeah, it can lead to some other crazy things.
Yeah.
But
So then kind of, you touched on anticholinergics, but thinking about those other medication classes. So, a lot of the times what we're treating, again, specifically in outpatient, probably also home health, that verbal impairment, that numerical reasoning, memory, reaction time, like you mentioned, perception. We see a lot of that already with our geriatric patients or our patients who have dementia, sometimes post-stroke, TBI. There's a lot of diagnosis that we could find any of these impairments in. But then when you think about those diagnoses too, there's a lot of different varieties of medications, plus whatever disorder they had before, whether that was a mental health condition, whether that was a pre-existing thing. So what are some of those other medication classes that we need to be looking out for?
yeah, so I wrote some of these down. Like, for instance, you could have an impairment in verbal numerical reasoning. When you give a test, you're giving a cog test, and you're like, well, what's up with, that, why they score so lowly? If they're taking amitriptyline, which is an antidepressant, it's not a common one as much anymore, but I do see still several people taking it for even different reasons. Maybe it helps them sleep or whatever. There's benzodiazepines. And those are, think Valium, Xanax, Klonopin, Ativan is very common. It seems like there's a couple of others. Those can definitely affect your verbal reasoning abilities. Not if you just take one and it's out of your system the next day and you're 40 years old, you'll probably be fine. But if you take them for a long period of time, there's some significant cognitive impairments documented in a pretty good amount of research. So we have evidence showing that, like for a couple of decades, and I have a lot of patient case studies that I could even share with HIPAA names, of course, that those benzodiazepines will affect brain function. And some of them get diagnosed with dementia, some of them get diagnosed with mild cognitive impairment because they've been taking those too long. And then even if a person with decreased pharmacokinetics are taking a benzodiazepine, it may still be in their system, in their body on day 2 when they go to take one again. And they take one on day 3, part of day 1 is still in their body, much of day 2 is still in their body and they've just taken a third one. And so it can build up a toxic effect if they're not excreting, and if they're fat soluble, if they're not excreting them out and distributing them. So that's a big one. And then Topamax is an anticonvulsant. A lot of anticonvulsants have cognitive effects where it's going to decrease their verbal reasoning function.
Mhm.
And then even to some extent, the research lists Tylenol. I'm not going to say a Tylenol is going to affect your reasoning function, but if you take it a lot and if you take too much of a dosage on a daily basis, I mean, I looked that back up like, is that right?
Mhm.
Really not. And it's always listed. And they even listed as paracetamol, which is what they call Tylenol. It's, the generic in Europe,
Yeah.
like UK. So that's for verbal numerical reasoning. And then other drug classes includes calcium channel blockers like amlodipine. And I see a lot of people taking that. Diuretics, because it's pulling out those different key electrolytes from your system, which is changing your fluid balance, which affects your brain. And diabetes drugs like the sulfonylureas, the metformin, some of those, which kind of makes me, every time I've been studying diabetic meds for years and how they affect a person and how they interact with antihypertensives, and compare that to their A1C levels and all of that. It's kind of complicated, and to their blood glucose level at the moment. So now that it's become a popular weight loss drug, it's kind of freaking me out because, when I teach courses, I frequently have people come tell me, metformin almost killed me. I had these horrible reactions to it. So there's a lot of side effects of those meds, and there's a long-term side effects. So I'm not, passing any judgment at all, but I just am concerned that people are not being told the short-term and long-term effects of them. But anyway, that the diabetes med can affect the verbal numerical reasoning, as well as decreased iron, proton pump inhibitors, several of those. And then impairments of memory includes back to the amitriptyline. So amitriptyline can affect the verbal reasoning as well as memory, the benzodiazepines. And then Keppra that's the brand name. The generic name is the levetiracetam. I always say that wrong. That Keppra does affect memory, and there's quite a few studies on that. And then there's some other meds like Seroquel, topiramate, and topiramate is Topamax, which is an anticonvulsant. Seroquel is often given for a range from bipolar disorder to depression to other types, because it also has a anticholinergic effect, which is trying to help the brain in some ways to keep, the neurotransmitters working, but it has other side effects as well. Impairments in reaction time includes amitriptyline, the benzamides, the benzodiazepines, the ones I mentioned, the Xanax and all those for anxiety. And there's others. Gabapentin is very common. Gabapentin is not as risky as some of the opioids, and so it's often given more often. Still has effects on cognition. And I always think about one time I went to see this home health patient. She was very young. She was like 52. She was a school teacher, wanted to get back to work, but she had just had her second stroke. And honestly, it was a reaction she says it was a reaction to taking a steroid, but I think it was mixed with something else that they gave her. Anyway, she had a stroke. So she lives by herself. She's dragging her right leg to the door to come answer the door. And she always did that, but she was pretty steady on her feet. She just had a partial paralysis of the right leg. And so I always start out every home health visit with, tell me what medications you're taking. Well, the first one, I have to write them all down. And I say, bring me that bag or the basket of your meds. And so then at the beginning of every other one, I say, have you taken anything different? Are you taking all the same meds? Nope, I'm taking all the same ones. I'm like, okay. And I'm thinking your dysarthria is significantly greater today. She's really slurring her speech. And she's less coordinated. It takes her longer to get to the door. I'm thinking she's a little shaky. What is going on here? So finally, you just learned what questions to ask a little bit differently. And I said, what were you doing before I came in today? And she said, oh, I was trying to wash some clothes and load the dishwasher. And I was just so tired. And I was in a lot of pain because she has neuropathy. She does not have diabetes, but she does have neuropathy. And I was like, well, what did you do about that? And she said, well, I just took 3 gabapentin. Her gabapentin is supposed to be 3 times a day. She took all 3 at the same time. I'm like, you can't do that. That's very, very dangerous. You know, you're going to fall and break a hip. Really bad side effects. She said, well, my daughter said I could. Her daughter worked at MD Anderson with leukemia. You know, I've spent a lot of time at MD Anderson. They give meds freely because a lot of them are in hospice. They're end-stage life. You want pain meds, we'll give you pain meds. Whatever. I'm like, not if you're living at home by yourself. No. You can't take 3 gabapentin all at the same time. Funny thing is, that was not funny at all, but she ended her home health thing and she begged the doctor, please give me 1 more round, give me 1 more month of home health. I really want to go back to work. So I went to see her back again. She was so excited about all these. We did high level cognitive stuff with her to get her back. And so I asked her meds that day and she told me all. It says, what about gabapentin? You're not on that anymore? No, that made me gain 30 pounds. I'm not taking that anymore. So she took it free if she thought it was going to help her pain, but when she realized that's what made her gain the weight, she completely stopped that
my
med.
gosh.
So it's always interesting to me what people will take because they think it helps. And sometimes they stop taking meds and they really need to be taking them because they don't like that side effect, you know. So anyway, gabapentin is one that can affect cognition as well as lamotrigine, often given for severe depression or other type of mental illness. There's a lot: opioids, risperidone, sertraline, trazodone. So a lot of the anti-epileptic or anticonvulsant meds, a lot of the psychotropic meds that are psychotropic makes, well, let me explain psychotropic meds. CMS, Centers of Medicare and Medicaid Services, describes a psychotropic med as an antidepressant, an anti-anxiety, a pain medication, a sedative, an antipsychotic. So they list all these different meds and they say basically anything that affects the central nervous system is a psychotropic, or anything else that has the similar effects to the brain is a psychotropic. But an antipsychotic is one of those mini meds, and that's a pretty serious med, drug class. Antipsychotics should be given for people with bipolar disorder, with schizophrenia, with psychosis, or manic depression, not regular depression. But instead, they're often given to people with dementia, and they are black box warning. They should not be given to people with dementia. It's written everywhere. It could cause death within a very few months if you give it. Still give them for depression, not for depression, for agitation or behaviors. And I hate that word behaviors associated with depression. It's their attempt to communicate because they don't have words often to say what they want to say. So those are pretty dangerous and they have a lot of side effects. So they're definitely going to affect coordination, cognition, and ability to function. It's going to shut them down, really. It shuts their brain down, it shuts their body down. So there's just a lot of those.
One of the ones too that you mentioned, Topamax, is often given too for migraine preventative, and they're giving that a lot to younger 20s, particularly females who maybe are, maybe don't have kids yet, maybe they're on oral contraceptives, and then they're having that as a reaction in some cases. Sometimes it's just hormonal. Sometimes we don't know what causes the migraines, but a lot of times I've seen that in our post-concussion syndrome patients as they're being given Topamax to prevent migraines when it's a symptom or a result of their multiple concussions or their pretty serious concussion, which seems, again, to be a huge warning label, really, in my mind. And I think the other really super interesting thing is when we think about normal aging and just some of the things that you've already mentioned with that process, just the reality of how increasing the risk of the adverse effects really with aging can kind of interact with cognitive decline, because we know that, we hear, like, my mother-in-law who had Alzheimer's would say, "Oh, well, I just have these memory problems because I'm getting older." And I finally just stopped trying to explain to them that's not
Yeah.
actually it's not actually a
Yeah.
thing.
Fine. Yeah.
It's not the same thing. But when you're looking at, our geriatric patients in particular, whether it's a normal aging process or all these things, other things that you've mentioned, and how there's certain generations, and I see it with my in-laws who are in their early 80s. They go to the physician says, "Oh, I'm gonna change your meds," or, "We're gonna add this. You had this symptom that could really be something very minor, but let's change your meds." And that's what we do. Every appointment, we change your meds. We're gonna
Mm.
increase this dose, we're gonna decrease this, and then the next thing you know, one of the two of them would have some sort of crazy side effect, not just related to a cognitive decline, but like my father-in-law had a reaction to, they had him on one of the diabetes meds, and he doesn't have diabetes because they were trying to lower his A1C, which was only like 7, and he's 81, which is
Yeah.
fine.
Yeah.
It's fine. Like, that's just not even
Why
a
go
thing.
through all those risks? Yeah.
Yeah, and he wound up in
That's
the
gonna mess
hospital
up
with,
all of your other body systems when you start messing with your insulin.
yeah,
Yeah.
yep, massive kidney issues.
Yes.
But again, back to the original part was just that normal aging, when we're increasing all these medications and the risk of all these adverse effects, and how that impacts people's cognitive decline.
Yes, because their kidneys and liver is working differently, which changes everything about their pharmacokinetics. Now
Hmm.
they're keeping those meds in their body. When I explain how an older person is probably going to lose muscle function. So I explain it as picture a man's arm when he's 25 is about this, his biceps about that big, let's say. And as he gets older, does an arm get fatter? Often doesn't even get thinner. It stays the same. It's just more fat, less muscle, unless he's doing a lot of resistance training. It's about the same size. It still looks about the same width, but because unless he's doing resistance training every day, unless all of us are doing resistance training, we're going to get maybe 1% more body fat every couple of years than before. And so we're just going to have more fat. And so it's going to be more fat soluble, less muscle, and that can lead to malnutrition. And a person could be very thin, but they still have very little muscle and more fat. And so it leads to malnutrition. And then the meds just sit in their body. So like if I should have 2 glasses in front of me. If I had 2 glasses and I filled up this one up to this much water and this one up to this much water, and I put like a little Kool-Aid pack or electrolyte pack or something in both of them, the one with a little bit water would be dark, right? And the one with a lot of water would be light color. Well, so for all the meds that are water soluble, in an older person is going to have less body water in their body. So we're made of a lot of water. An older person could be 40% less water in their body than a younger person. So there's very concentrated meds and they can't get out of their body. So they're having a lot more side effects because the liver can't metabolize and the kidneys can't excrete. And so it changes everything. So aging is associated with, with a lot of changes. We also have motor changes, cognitive changes, maybe hearing and vision changes, and all kinds of things. But our pharmacokinetics and pharmacodynamics, and something about, I will say, with pharmacokinetics, the absorption, how the body absorbs the drug is usually complete, just takes a lot longer to get there. Some of the others, it's not complete. It doesn't completely excrete out. It's just, so some are slowed and some are incomplete in that process, which can lead to a lot greater side effects.
Well, and again, when we're thinking about our geriatric patients, whether they have something like an Alzheimer's or other type of dementia or not, what do we hear a lot of, especially from the, I don't hate to pick on the ladies, but those of us who have had any kind of pelvic floor issues with surgeries or children or what have you, a lot of times what we hear is, well, I don't like to drink a lot of water because every time I cough or every time I sneeze, I have a leak a little bit or whatever. And so we see a lot of times the incontinence that occurs as part of some aging processes. And you see it in male patients too. It's not just strictly women, but a lot of
Right. Yeah.
times what happens is they don't drink enough water because they're scared they're going to have an incontinent episode. And then
Yes.
they're also on a diuretic, and now they're dehydrated halfway by themselves, and now they're on this new med that's making them all the way dehydrated. And then, like you mentioned, we start seeing these patients in acute care who are now hypokalemic. Their potassium levels are all off, their sodium levels are all off, whether they're low, high, one's low, or vice versa. And it just becomes this whole cycle of a big old mess, is what I would
Yeah.
call it.
Yes.
And it is hard to, and I think it's hard because we don't learn that in graduate school. And if you do go into medical setting, it's sort of like this on the job training. But I've noticed that not everybody is mindful of that, depending on your setting and how invested you are in learning about, those patients. But when you're working in an ICU or you're working in the LTAC, the long-term acute care, those things can really be game changers for those patients. And it really doesn't take long
Absolutely.
to see any of that be really impactful on their overall, like the holistic care of the patient.
Yes. And by the time they're dehydrated, they're already shot. The brain's
Hmm.
just not working well. You can't just give them a glass of water and it all comes back. It's a complicated process to get them hydrated again. Now, sometimes if they're connected to an IV and hydrated that way, their brain kind of kicks in again. But if we're just trying to get them to take sips and drink, and please drink your cranberry juice, please drink your water. Oh, can't, honey. Then I'll have to go to the bathroom. And then their medications are stuck in their bodies and they're not working. So yes, it's so common. And then, older people also have a decreased thirst. They're
Hmm.
not thirsty. And then if they have dementia or Alzheimer's disease, that further complicates their thirst. And they're taking anticholinergics, which anticholinergics is a lot of meds. It's like 400 or more meds or anticholinergics. They are meds that a lot of them start with except for antibiotics. So the anti-anxieties, antidepressants, anti-Parkinson's, anti-this, anti-that. They dry up the saliva in the mouth. They cause urine retention, which is great if they're on an operating table, that they're not urinating or, choking on their saliva. But they also have a lot of negative side effects as well. So this is an adverse effect of a med that's doing a good thing. So the pharmacodynamics is good. It's what you want. It can stop a tremor, for instance. It helps restless leg syndrome. It helps Parkinson's. So it decreases these extrapyramidal things going on, but it dries up everything. So, Renee, what you're talking about, if they're also not getting hydration, they have no saliva in their mouth. Now they can't swallow. And there's
Hmm.
children who takes anticholinergics as well that dries up their mouth and they don't have enough saliva, and you wonder why they're choking. Because lack of moisture in food has a huge effect on, a person's ability to swallow or not swallow effectively. So there's a lot, right? So much
Yeah.
involved.
Yeah, for sure. Yeah, and again, I think, I love to think that our graduate programs are doing a great job, but really a lot of this is more seeking out your own knowledge and knowing that the setting you're working in, you may really have to do. I did take, when I was a relatively new grad, I was within the first 8 months, I think, after I was a CF still, I took a really good course on drug interactions, and not just for one diagnosis or the other, because I was primarily seeing TBI and stroke patients and other progressive neurological diseases. But it was really helpful to get that base knowledge, because it does
Yes.
take a lot of time to understand that, even with lab values, same thing, because like you mentioned, the meds are there to help improve sometimes the lab values, but then it can decrease other things that can also impact the lab value. So it's really this tricky balance that you just have to be
Yes.
mindful of, because when it comes to things like dysphagia, we know that, your saliva is starting to break down the food as soon as it gets in your mouth in the liquid. And if you don't have saliva or don't have, enough of it, that piece can impact your digestion as well. So it's a whole tricky slope. Your body is complex, and like I'm noticing as my doctor calls it maturing, not aging. As I'm maturing, my body's doing weird things now. So I'm very grateful that I don't have to take
And you're like, "Is that a
medication.
compliment?" That I'm maturing? Yeah.
Well, I think we're about the same age, and so he doesn't
Oh,
like to say he's aging, so he says we're getting mature.
I love that. I do tell people never call a person the geriatric or the elder or the elderly or the old person, but you can always say they're older than somebody
Yeah.
else. I'm
Yeah, the
older
only
than
person I can do that with is my father-in-law, who has a great sense of humor. So I'm always like, you sound a little old right now, or your geriatrics hanging out. Put that back in your pocket or something
uh-oh.
like that. But I would never do that with
We're
a
all older
patient.
than somebody. Everybody on this podcast is older than somebody because somebody was born yesterday and we're older than that person.
There you go. We have about 5 minutes left. So, what are some examples of case studies that you would say you really could share that you noticed that the medications really impacted their cognition?
There's so many. I'll just tell you a couple. One, I think, Renee, that I reference on another call that we were on, is a 50, she was maybe 54, and I knew her personally, but I had not seen her for many years. And she knew that I a lot of courses around the country on dementia, and she knows that. And, for 20 years I have. And so she messaged me on Facebook and said, "I just wanted you to know I have dementia." And I'm like, "What? You're like 53 years old." And she said, "Yes. And I've gotten a second opinion and I failed all the tests and they're calling it mild cognitive impairment at this point, but I have, they're saying it's early Alzheimer's disease because she failed all the neuropsych tests and she
Mm,
went to really good hospital systems with great neuropsych departments. And so she was an attorney. And so she planned to find the right person to sell her law practice to. And then she told her son what assisted living memory care unit she wanted to go into. I'm thinking, you're 53 years old. And she couldn't remember anything from day to day. And she just every day woke up and kind of checked herself. Do I need to move to the memory care unit today? And as she keeps telling me she has dementia, I'm like, I don't think so. First of all, her syntax is still pretty intact, when she's writing to me. So I was teaching a conference in her city, and I let her know. I thought maybe I should go by and visit her. And she said, "No, I'll meet you at the restaurant." I'm thinking, okay. And so she came to meet me, and she looked lovely. And she said, "First of all, I don't have dementia." And I was like, "Well, I didn't think so, but what happened?" And she said, "Well, my doctor retired. I got a new doctor, and I just walked in. I had a sinus infection or some kind of upper respiratory thing. And I walked in. I said, I just want to let you know I have dementia." And they're like, "What?" And then the doctor had the presence of mind to say, "Let's check some other things. Why you failed all those neuropsych tests." And in the process of asking a ton of questions, she found out that this person, I'm going to call her Miss MJ, is the HIPAA name I gave her, had been taking Klonopin for 25 years because she was in a very, very stressful law practice. Her husband was an international law attorney. Then they got a divorce. It was very complicated. And she was highly stressed. She never chose counseling. She should have. I mean, I think it's a great way to deal with stress. In fact,
mhm.
I just wrote a book about dealing with stress, about resilience.
Yeah.
There's things to do to deal with stress. And yes, anti-anxieties, antidepressants, all that is great, but it should be a part of a whole plan. But she did
Mm,
nothing else. She kept upping the dose because you get you get used to
tolerance.
a tolerance. Yeah.
Yeah.
So the physician said, "Let's do a gradual dose reduction of your Klonopin and let's get you some counseling, get you some strategies. And then after several weeks, you can't ever just stop taking those. You'll have seizures and it could lead to death. You don't ever want to just stop taking a benzodiazepine." And she said, my brain came back. It's a long story. But the bottom line is she said, "And I've taken my GRE again. I've decided to go back and get my master's in social work. And I was like, but you're an attorney. And she's like, I know, but I think I could help my clients more if so she worked with older people. I think I could also help them if I was a social worker. And I'm thinking, I don't think I could pass the GRE again. That was a long time ago. And she got accepted. But the point is, her brain was completely shot. And when she got off of them over like months, and she went to a therapist and to counseling, her brain came back. And the doctor said, it's you cannot take benzodiazepines for decades. That one of many examples. So, and I've seen it a lot with people. And kind of like you said, sometimes they're on 20 meds, you gradual dose reduction, get them down to 5, and they wake up. And a lot of times we need to see them for cognitive therapy to retrain their brain, because they haven't been using it in a long time.
Well, and a lot of times too, when you go in again, and I'm not picking on physicians, I think just like many of us in healthcare, they're overstressed. Their patient loads are insane. They work a ton of hours, and sometimes the quickest fix is to change the meds or to add a med. And, I've had something going on recently, and the first thing they wanted to do for pain was give me Dilaudid, and I almost fell out of the bed. I was like, no, I'm not taking that. That's like what the pain seekers in the emergency room come in for. I would die if you give me that.
Yes.
I'm such a lightweight. I'll take a Benadryl tonight. I'll see you next week. So no.
Yeah.
But again, I think that that's just part of the culture and part of the fast-paced craziness that healthcare can sometimes be. So having that second set of eyes, again, we're not pharmacists, we're not claiming to be, we're not prescribing physicians, but being knowledgeable so that we can ask the right question, or maybe say, hey, this seems off. I noticed this symptom with a patient. There's nothing wrong with that, and working as a multidisciplinary teammate.
And sometimes we see them for 30 minutes or an hour every day, or 5 days a week, or 3 days a week, or whatever, and nobody else sees them as much as we do. So we are the eyes often of the prescribing practitioner. They're certainly not seeing them an hour a day for 5 days a week. So they depend on us to let them know.
Oh, exactly. Well, thank you so much, Lisa, for joining us.
It's
I really
fun.
appreciate you agreeing to do this. I know you're a busy lady, and you have a lot of knowledge in this area, though. So I'm really grateful that you shared that with us, because it was a great learning experience for me too, not just for our participants and listeners. Thank you again, and look forward to seeing you.
Thank you, everybody.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Each episode comes with an accompanying audio course on speechtherapypd.com, available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with promo code BRAINSTORMS20. SpeechTherapyPD.com is run by SLPs for SLPs. We've got the largest library of ASHA CEU eligible courses out there, adding fresh content every week. Remember, use BRAINSTORMS20 to get $20 off access to over 1,000 courses for an entire year. Head over to SpeechTherapyPD.com for more information and start earning CEs today. Thanks for tuning in to Brainstorms, Functional Neuro Rehab for SLPs. And don't forget, SpeechTherapyPD.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us. We'd love for you to drop us a quick review and hit that follow button.